Benign prostatic hyperplasia. So, what are your causes of your benign prostatic hyperplasia? They include your increased estrogens, intermediate peptide growth factor, metabolic syndromes, and various hereditary factors. So, what happens in your benign prostatic hyperplasia? Now, it affects both of your glandular epithelium and your connective tissue stroma. It mainly affects your transitional zone of your prostate. So, there is a compression of your peripheral zone causing a false capsule and the formation of your lateral lobes. Now, when it affects your central gland, then the middle lobe that develops project into the bladder within the internal sphincter. So, if you look at this diagram, so this is your enlargement of your median lobe of your prostate, and this is your enlargement of your lateral lobe of the prostate, right, because of the compression of your peripheral zone. So, this is your basic pathology with respect to your benign prostatic hyperplasia, where you would have to remember that it occurs in your transitional zone affecting your glandular epithelium and your connective tissue stroma, formation of your lateral lobes, and when it affects the central gland, the middle lobe develops that project into the bladder within your internal sphincter. Now, what are the consequences of your benign prostatic hyperplasia? So, the consequences could be no symptoms and no bladder outlet obstruction. It would be remaining dormant, causing no symptoms to the patient. There could be no symptoms, but a urodynamic evidence of your bladder outlet obstruction. Then it may present with your LUTS, that is your lower urinary tract symptoms without any evidence of your bladder outlet obstruction, or it may present with your lower urinary tract symptoms as well as your bladder outlet obstruction. And the other consequences include your acute or chronic retention, hematuria, urinary infection, and your stone formation. Right. Now, anatomically, what are the effects? Now, if you look at the urethra, the prostatic urethra is lengthened, sometimes almost twice its normal length, but it is not narrowed anatomically. The normal posterior curve may be so exaggerated that it requires a curved catheter to negotiate it. Then, when only one lateral lobe is enlarged, distortion of the prostatic urethra occurs. So, these are your anatomical effects that occur at the urethra. Now, when you look at the bladder, the musculature of the bladder hypertrophies to overcome the obstruction and the appears trabeculated, right. So, if you look over here, these are your trabecular formation in your bladder. Then your significant BPH is associated with your increased blood flow, and the resultant veins at the base of the bladder are apt to cause your hematuria. So, because of this increased blood flow, they may prone to be ruptured and cause your hematuria. So, these are your anatomical effects that occur at the urethra and at the bladder because of your benign prostatic hyperplasia. Please remember that there is lengthening of the prostatic urethra, and at the bladder there is formation of your trabeculae. Now, regarding the management, the assessment would be as we had discussed in your part 1 with the various techniques of your ultrasonography and your cystourethoscopy and your CT scanning as and when indicated, right. So, the management, your indications of your treatment would include your acute retention, then your chronic retention and your renal impairment, complications of your bladder outlet obstruction, hemorrhage and your severe symptom. Now, the medical management includes your alpha adrenergic blocking agents. So, they inhibit the contraction of your smooth muscle in the prostate. The second group of drugs that is used in your BPH is your 5 alpha reductase inhibitors. Now, they inhibit the conversion of your testosterone to 1,5 dihydrotestosterone. Now, your standard treatment is your prostatectomy. So, if you look at this image which shows your surgical approaches to your prostate, we have your transurethral approach, a perineal approach, a retropubic approach and an approach through your bladder. So, transurethral resection of prostate remains the most commonly performed procedure for the surgical correction of your bladder outlet obstruction. So, what happens over here is the strips of tissue are cut from the bladder neck down to the level of varium montanum. Now, this cutting is performed by your high frequency diathermy current, which is applied to across a loop mounted on the handheld trigger of your resectoscope. Now, coagulation of the bleeding points can be accurately also achieved with the help of this. The chips of prostate are removed from the bladder using an Ehrlich evacuator. Now, this resection proceeds at 1 gram per minute in experienced hand. And what will be the duration of resection of your monopolar TURP? It is usually limited to 1 hour due to the risk of resorption of water if 1% glycine is used as an irrigant. Right. The advent of bipolar TURP, where normal saline is used as an irrigant, permits resection of your larger prostates and also a larger operative time. So, the following TURP, a careful hemostasis is performed and a 3-way self-retaining catheter is irrigated with isotonic saline introduced into the bladder to prevent any further bleeding, forming the blood clots. Now, the irrigation is continued until the outflow is your pale pink and the catheter is usually removed on your second or third post-operative day. So, this is also a very important question that is asked, that when is your catheter removed following your prostatectomy? It is usually on the second or your third post-operative day. And now, in men with small prostates or bladder neck dysgenesia or stenosis, it is better to divide the bladder neck and prostate urethra with a Collins knife or a laser. So, if you look, now this is your diagrammatic representation of your transurethral resection of the prostate. You can see over here the prostate gland, the prostate tissue being removed with the help of a resectoscope. Now, the modern day techniques, we are also doing your laser prostatectomy, which includes your HOLEP, that is your holmium laser enucleation of your prostate gland. Right. Now, there are few complications that you need to understand with your prostatectomy. So, what could be your complication? Your complications are your hemorrhage, sepsis, incontinence, retrograde ejaculation, urethral stricture, bladder neck contracture and water intoxication. So, this water intoxication needs a special focus. So, what happens over here? So, if you see, the absorption of water into the circulation at the time of TUR can give rise to congestive cardiac failure, hyponatremia and hemolysis. Please remember hyponatremia, right. So, this is the most commonly question asked from here. Now, it can also lead to confusion and other cerebral events, often mimicking like a stroke. So, if you get a scenario where a patient has undergone TURP and presenting with this symptom, please remember that they might be hinting towards your water intoxication. So, the incidence of this condition has reduced since the introduction of your isotonic glycine for your irrigation during resection, and further still with the development of your TURP where saline is used as an irrigant. Now, what would be the treatment? The treatment of this is your fluid restriction, right. So, these are your two important keywords that you guys need to remember, hyponatremia, and your treatment is your fluid restriction. Now, a last important point is, what are your things that you need to counsel your patient before he goes for your prostatectomy? It includes your retrograde ejaculation, erectile dysfunction, which is seen in 5 to 10%, risk of reoperation, morbidity rate and your incontinence, right. So, this were your few important points with respect to your BPH and your TURP. Please do not forget to revise your water intoxication, where you have your hyponatremia, and treatment would usually consist of your fluid restriction. Thank you.